Okay, guys, we've got to get going. Dr. Nayak's got to get to the airport. He's not feeling well. I've got to get to endocrinology, and we've already used 6 minutes. So we're really fortunate today. We've got Rabbi Nayak. He's a professor of medicine and runs the pulmonary division, and he's going to talk on something I know nothing about, interstitial lung disease. Thank you, Rabbi.
Thank you, Dr. Molly, for inviting me to talk to your division about interstitial lung disease and IPF. What I'm going to do is, in the first few minutes, I will discuss the approach to diagnosis of interstitial lung disease. Then I will focus on idiopathic pulmonary fibrosis in elderly. And I have a lot of slides for fellows regarding the other types of ILD, and so I can upload it on my Google Docs and share with all the geriatric fellows. Okay? So I do not have any financial relationship or any conflict of interest with this talk. Okay. So I'm going to discuss the symptoms and signs of interstitial lung disease. Then we'll discuss the various types of interstitial lung disease, and then I will discuss about IPF in elderly. So Dr. Moley was joking that he didn't know anything about ILD. All we have to know is 3 things. The hallmarks of ILD. That is progressive shortness of breath or cough, restrictive physiology on pulmonary function tests, and diffuse pulmonary opacities on chest imaging. These are the 3 hallmarks of interstitial lung disease. Okay, this is a broad classification of different types of interstitial lung disease. You know, it could be idiopathic interstitial pneumonias, connective tissue disease, hypersensitive pneumonitis, pneumoconiosis, drug-induced pulmonary disease. For this crowd, the 3 most important medications you need to remember is methotrexate, nitrofurantoin, and amiodarone. Okay, and sarcoid, eosinophilic lung disorders, pulmonary vasculitides, alveolar hemorrhage syndromes, and miscellaneous. Okay. Clinical features, I already told you, symptoms, dyspnea, and non-productive cough. When they present acutely to our intensive care unit, they may have a flu-like illness, like low-grade fever. That's usually with acute interstitial pneumonia or cryptogenic organizing pneumonia. Famous bibasilar crackles can be heard in these patients on auscultation. You have to remember 2 things about clubbing. Clubbing may be present at the time of presentation. If a patient does not have clubbing at the time of diagnosis, but develops clubbing down the road, in 6 months, please think about development of lung cancer from the scar. Okay? When you're hypoxic, you can develop cyanosis. Medical history, we need to take history like medical students, that to 30-year medical students. We have to take detailed environmental and occupational history, evaluation of the current medications, and never forget to ask over-the-counter medications. I already mentioned history of nitrofurantoin is very important for your patients because we may put them on for chronic suppression of UTI. And so please get the detailed history of those medications. And determining the tempo of progression of respiratory symptoms. Some diseases are acute and some are subacute to chronic. Acute are like alveolar hemorrhage syndromes. Chronic, usually idiopathic pulmonary fibrosis or sarcoidosis. Okay. Lab tests, we need to get appropriate tests. The patients may, some patients with interstitial lung disease may have eosinophilia, and we may have to suspect eosinophilic lung disorders. Usually these patients also have symptoms and signs of asthma. We are very good about working on the patient for connective tissue disorders, and we need to get anchor antibodies for Wegener's or microscopic polyangiitis. Anti-globular basement membrane antibody, Goodpasture syndrome, is extremely rare, but I see many times the patients have the anti-GBM antibodies ordered, but they do not have the usual test. Make sure that you work them for rheumatoid arthritis, lupus, anti-RNP antibody, and usual conditions. Okay. I would like to spend a minute on pulmonary function test. One of the hallmarks of ILD is restrictive physiology. What does that mean? That means the decrease in FEV1 and FVC, but the ratio is normal or elevated. And the total lung capacity by plethysmography is less than 80% of predicted. And they also have decrease in the diffusion capacity for carbon monoxide. Okay? Arterial blood gases are helpful to find out whether patients are hypoxic at rest or not, or whether they are retaining carbon dioxide. If the patient is not hypoxic, you may want to do cardiopulmonary exercise test. The patient may be hypoxic during exercise test. Okay? That's very important for the further workup. I would like to spend about 4 to 5 slides or more on radiological studies. And my target for this one is all the fellows and the residents here. One of the main features of interstitial lung disease is abnormal chest radiograph. If I gave this talk about 10 years ago, I would say you need to do a biopsy for diagnosis. Now we have become so good in high-resolution CT scan of the chest, we can avoid biopsy. And it's for geriatric consultants here too. You don't want your patients to undergo biopsy when we can tell you confidently that this patient has this particular diagnosis and we can avoid biopsy. We need to learn about different patterns, reticular, nodular, reticulonodular patterns. During standard chest X-ray or a CT scan, standard CT scan, conventional CT scan, we can miss about 10% of the interstitial lung disease. That's why we should go for high resolution CT scan of the chest, okay? To understand high resolution CT scan of the chest, we need to understand what is secondary lung lobe, okay? It's essential. It's the basic anatomic unit of pulmonary structure here. Okay? So it is the smallest lung unit that is surrounded by connective tissue septa. Okay? You can see in blue the centrilobular artery and the terminal bronchiole run in the center. Okay? And the lymphatics and the vein in the rich in red run within the intralobular septa. So after this lecture, please try and look at some of the high-res CT scans. Okay, and secondary lobule, it measures about 1 to 2 centimeters in size. It is made up of 5 to 15 of pulmonary acini that contain alveolar gas for exchange. It is supplied by small bronchiole. As I said, it's the terminal bronchiole in the center that's parallel by the centrilobular artery. And just to repeat, here we have the lymphatics and the pulmonary veins. Okay. Pulmonologists and chest radiologists are like real estate agents. We go for location. Where is the opacity? And the dominant pattern, distribution within the lungs. Okay, is it the reticular pattern, nodular pattern, high density, low density, centrilobular or perilymphatic and random, whether it's upper zone or lower zone, or central or peripheral. I have a few slides for that. Let's go for the upper lobe predominant. What are the lesions we can have? Sarcoid, primary Langerhans cell histiocytosis, silicosis, and hypersensitive pneumonitis. Just to keep my residents awake and alert, do you know why they are upper lobe predominant? Because these are all exposure-related diseases. Okay? Sarcoid, we do not know the exact cause, but there are some hypotheses. It could be due to some exposure. Okay? Pleural-based or reticular opacities, idiopathic pulmonary fibrosis. If you have intrathoracic lymphadenopathy, it could be sarcoid or lymphangitic spread of cancer. Okay? Spontaneous pneumothorax, it can be associated with the two rarest of interstitial lung disease. One of them is lymphangiomatosis and pulmonary Langerhans cell histiocytosis. Pulmonary Langerhans cell histiocytosis, we had with Dr. Yep in the smoking. This is always smoking-related lung disease. Primary Langerhans cell histiocytosis. LAM is always in women in the reproductive age group. Please remember that. Okay? Upper lobe versus lower zone. Sarcoid, cold workers pneumoconiosis, emphysema, Langerhans cell histiocytosis, chronic hypersensitive pneumonitis. Chronic hypersensitive pneumonitis is a great mimicker. So you should always think about this diagnosis when you are working with a patient for ILD. And only way you can diagnose this with a good history. Okay? Lower zone could be edema, panlobular emphysema, UIP. Okay, UIP is a pattern which I'm going to explain to you in a little bit, and there are two differential diagnoses for that: connective tissue disease and asbestosis. Central zone, again sarcoid and bronchitis. Peripheral zone is cryptogenic organizing pneumonia. This is a dense consolidation in the periphery, okay? Chronic eosinophilic pneumonia, hematogenous metastasis, and UIP. And I talked about this once before. Hilar and mediastinal adenopathy with interstitial opacities could be lung cancer, lymphangitic spread of lung cancer, progressive systemic sclerosis, TB, sarcoid, poll workers pneumoconiosis, silicosis is rare. Okay. Next, I would like you to write down this website. This is a very useful website for radiology assistant.nl. This NL stands for Netherlands. Okay. This very useful website, not just for chest, even for other radiology. Okay. It's free. You don't need any password or anything like that. Okay. So I will make it very simple for you. There are three types of lung nodules when you look at the films. Centrilobular, it does not touch the pleura. Okay. Perilymphatic, here, it's always on the pleura and along the vessels. Okay. And in between is random. Okay. So this is the way we approach. We see the multiple nodules. So they touch pleura, subpleural, septal, peribronchovascular, perilymphatic distribution. Only few things come to your mind: sarcoid, silica, lymphangitic spread of cancer. Touches the pleura, random distribution, miliary, and metastatic lesions. Okay. No pleural, centrilobular distribution, hypersensitive pneumonitis, respiratory bronchiolitis is another smoking-related interstitial lung disease, and bronchoalveolar cancer. Okay, but two things you should remember about random for your boards is hypersensitive pneumonitis and respiratory bronchiolitis. Famous question: ground glass versus consolidation. Okay, so this is consolidation. Architecture is distorted. You cannot see things through and through. But in ground glass, architecture is maintained and you can see the structure through and through. That means ground glass opacity. Very simple. Okay? So the other words we use is honeycombing. Okay, it stacks one above the other. Traction bronchiectasis is the lung fibrosis pulling the bronchial wall. Okay? Lung cysts covered by the normal healthy lung tissue. This is centrilobular emphysema. This is signet ring sign for again for bronchiectasis. This is the vessel that is corresponding with the bronchial tube. Okay. Some people call it Elizabeth Taylor sign because it looks like a diamond. Okay. Small diamond for Elizabeth Taylor. Okay. And here is the patient. The reticular opacities on a regular chest X-ray. This is the patient with silicosis. Here you see all the coalescing of the fibrosis, and this is like the progressive massive fibrosis. This is the lymphangitic spread of cancer. You can see the curly B lines. Okay, this is the enlarged view of curly B lines. But we don't have to struggle anymore with the high-res CT scan. Okay, this is an example where you have a normal chest X-ray and CT scan picking up the. This is centrilobular pattern. Okay. Like in sarcoid. Okay, this is one more view of sarcoid, central pattern. Okay, this is the patient with lymphangioliomatosis, cystic lung disease. Happens only when women can present with spontaneous pneumothorax. Okay. Fibrotic bronchoscopy. What's the role of bronchoscopy? If you ask my fellows, they think everybody should undergo bronchoscopy. Okay, but it is not a useful test in patients with ILD. When you suspect infection and blood, it's an awesome test. Okay. So diffuse alveolar syndrome, it is the modality of diagnosis. Okay. Eosinophilic pneumonia, BAL is helpful there. And pneumocystis is It's an excellent test. So BAL is useful for diffuse alveolar hemorrhage, eosinophilic pneumonia, and infections. Okay. Bronchoscopy, transbronchial biopsy. If you have granulomatous disease like sarcoid, berylliosis, it's still a good test. Lymphadentic spread of cancer, but it is not useful in idiopathic interstitial pneumonia. Please remember that. Okay. Surgical lung biopsy. I've been doing this talk for last 11 years, okay, and my slides have been changing because we had only consensus guidelines in 2001. First time we had evidence-based was in 2011. After that, we have 2 revisions, okay. It used to be the key modality of diagnosis in the past, okay. The video-assisted thoracoscopic surgery is more tolerable by the patients, okay, but confident diagnosis can be made, especially in geriatric patients, and we should not subject them to unnecessary surgery. One of the things that happens after subjecting the patients for unnecessary surgery is they can develop acute exacerbation of ILD, and they will not come out of the ventilator. But if the presentation is atypical, CT scan does not fit, then you can make a case for a surgical lung biopsy. Okay. This is the revised classification in 2013. So it's made quite simple for us. Okay. This is IIP is idiopathic interstitial pneumonia. These are the major and these are the rare, and then we have unclassifiable. Idiopathic pulmonary fibrosis, I'll be speaking in detail. Close behind that is idiopathic non-specific interstitial pneumonitis. Please remember these 2 are smoking-related interstitial lung disease. Treatment for this condition is smoking cessation. Okay? Cryptogenic organizing pneumonia presents like a consolidation. Okay? And you have to rule out bacterial pneumonia. If you have a patient who does not respond to antibiotic with azithromycin, levofloxacin, and then treatment for hospital-acquired pneumonia, think about cryptogenic organizing pneumonia. Acute interstitial pneumonia, this old Hamann-Rich syndrome, and they are always in intensive care unit. Okay, this is mimics ARDS. These 2 are rare. I'm not going to spend time on those ones. Okay. What happened? So again, chronic fibrosing idiopathic interstitial pneumonia. 2 things. UIP is a pattern on a pathology, which I will explain to you. NSIP is the opposite of UIP pattern. Okay. Smoking-related interstitial pneumonia or RBILD and desquamative interstitial pneumonitis. Pathologically, clinically, this is the pattern. Okay. This is what the pathologists give it to us when we subject them for surgery. And this is what we do. We call something called a MDD, multidisciplinary discussion, between pathologists, this among pathologists, clinicians, and radiologists. If a pathologist tells us usual interstitial pneumonia, if there is no connective tissue disease, no asbestosis, we clinicians diagnose idiopathic pulmonary fibrosis. Pathologist says non-specific interstitial pneumonia, we have done a diligent work of connective tissue disease, hypersensitivity pneumonitis, we don't find anything, then we diagnose idiopathic non-specific interstitial pneumonia. Here, not much of confusion here, respiratory bronchiolitis and DIP. Organizing pneumonia, pathologist does not call it cough, it's up to us to call it cryptogenic organizing pneumonitis. Okay? Diffuse alveolar damage, okay, DAD. This is the same pattern you find in ARDS, but if the clinical picture does not fit with ARDS, please think about acute interstitial pneumonia. Okay. Now I'll be talking about, so far you have any questions about approach to interstitial lung disease? Because now I'll focus predominantly on IPF in elderly.
What did BOOP used to be? Remember?
Okay, thank you for that question. Angela's question is, what's BOOP? BOOP used to be organizing pneumonia.
Okay.
Okay? So they took out that word quite some time ago. It was called bronchiolitis obliterans organizing pneumonia. Okay, it used to be the old name for that. It appears like a consolidation, low predominant. Okay, people thought if it was associated with connective tissue disease, it was BOOP. If it was idiopathic, it was cryptogenic organizing pneumonia. They took out all those things.
Okay,
They made
so that's a revision.
Organizing pneumonia, no cause, cryptogenic organizing pneumonia, and if you have a cause, it becomes a soft cryptogenic organizing pneumonia. Okay, no more BOOP. So IPF is the most common idiopathic interstitial pneumonia, affects about at least 200,000 persons in the US, and you are the ones who will see these patients the most. Common age group is 50 to 70 years. Median survival, I put it 3 to 5 years, but I will show you the brand new slides from 2015 here. The exact cause is not known. About 0.5 to 3.7 cases are familial, and 60% have the history of smoking at the time of diagnosis. Again, repetition here. Idiopathic etiology of usual interstitial pneumonia is IPF. Okay, it's generally a chronic and relentlessly progressive disorder. This diagnosis is worse than some of the cancers that we know of. This is the slide I want to show you. Annual incidence and cumulative prevalence in Medicaid beneficiaries from 2001 to 2011. The prevalence is going up, so is the incidence. And do you know how much it costs Medicare? It costs about $2 billion. But we still do not have any policies to manage IPF. So clinical symptoms, go ahead.
Do you think that's a real increase, or is that just we're better at diagnosing?
I think it's better at diagnosing. You know, remember, until 2001, even when I was a fellow, first 2-3 years, we did not even have a consensus guidelines. The consensus guidelines was in 2001. And I think, and higher CT scans started getting better in early 2000s. So I think it's better diagnosis. Symptoms is breathlessness, non-productive cough, bibasilar crackles, and clubbing. Okay? On physical exams, you can find crackles and clubbing. And just to repeat, you have normal FE1 FEC ratio, decrease in FE1 FEC, and total incapacity less than 80% of predicted. DLCO is definitely decreased. Okay? And please remember, if a patient with ILD, if they are not hypoxic, please walk them in your clinic. They may be hypoxic with activities. And also order overnight pulse oximetry. They may be hypoxic only during sleep. Okay? This is the classic. If I convince you with this picture today, my lecture is worth it. Okay? This is the classic UIP pattern. Please remember this one. Okay? I'll go slowly. So, in the usual interstitial pneumonia, it is heterogeneous. Okay? It is subpleural, and you have this peripheral reticular opacities, and we have this septal thickening. Please remember my secondary lobule. So you can say that these are all the secondary lobule here. We have the septal thickening, subpleural, this honeycombing, and this is the traction bronchiectasis. That's why I showed you all this introductory films earlier. If you see this, if Dr. Parker sees, he will say that it is UIP pattern. What you do is you work them up for connective tissue disease, ask them about detailed history about asbestosis, then make sure that they are not on methotrexate, amiodarone, or nitrocurantine before you diagnose pulmonary fibrosis. Okay. But what are the inconsistent features? If you have any of the 7, then it's not a UIP. Okay. If it is, instead of being low predominant, what if it is upper and mid lung predominant? Then it's not. What about bronchivascular predominance? If you have any ground glass opacity, remember I showed you what is ground glass, and if you have nodules, you don't have nodules in IPF. Okay, discrete cysts, not honeycombing cysts. If you have cysts, it's not okay, or mosaic attenuation or air trapping, or consolidation. Please remember, if it's consolidation, you think more in terms of organizing pneumonia. Okay? So, some more pictures here. This is the classic UIP pattern. Okay? Low predominant, honeycombing. You have traction bronchiectasis. Okay? And this is also the idiopathic pulmonary fibrosis due to UIP pattern. But this is not one. Here we have some ground glass opacities here. This is not the one. So panel A, panel B, C and D are still UIP. Okay. Like we have UIP pattern on radiology, we also have UIP pattern on pathology. What is that? It mimics radiological pattern. Okay. You have marked fibrosis, you have architectural distortion, honeycombing, predominant in subpleural and paraseptal distribution, and it's patchy. Okay, and you have the pathognomonic feature is fibroblastic focus, and any other features should not be there. Okay, so let me explain to you the picture. If you have hyaline membranes, it is not. Hyaline membranes are usually present in diffuse alveolar damage, which is present in ARDS or acute interstitial pneumonia. Organizing pneumonia, I talked about the cryptogenic organizing pneumonia. Granuloma, you see it in sarcoid or TB. Okay? And any airway center disease, predominantly airway features. Okay? Let me show you some pictures here. So, this is the pleural. And you see here the inflammation. This is the fibroblastic focus. You have good areas of the lungs and bad areas of the lungs. So you have heterogeneity. Okay, fibroblastic focus here. Okay, fibroblastic focus. Okay, and this is the gross anatomy, the pleural-based lesion. So good area of the lungs, fibroblastic focus, and intense inflammation here. So in NSIP, CT scan shows ground glass opacities, it shows uniformity and homogeneity. Homogeneity is found in non-specific interstitial pneumonitis. Heterogeneity is found in usual interstitial pneumonia. This is the main difference, both radiologically and pathologically. So we suspect a patient with IPF. Any identifiable causes of ILD? No. High resolution CT scan of the chest? And UIP pattern, you can confidently diagnose IPF. And this is what you want to do in your group of patients. Okay? Yes, and then we have not IPF. Okay? Some cases, high resolution CT scan is possible UIP or inconsistent. We may have to go for surgical lung biopsy. Biopsy finds UIP features. Okay, then we have to have a multidisciplinary discussion before we diagnose IPF. Okay? Any questions on the diagnosis on that one? So please remember, you have to have shortness of breath and cough, crackles and clubbing, UIP features on pathology, UIP features on radiology, then you make a diagnosis. Okay? Predictors of reduced survival in IPF. I have some slides and some of them may be repetition, but I think they're important. Coexisting emphysema, okay, has been found out to be a very important cause of mortality in these patients. And I would like you to request one thing. If you see a patient with emphysema and DLCO is very low, please shoot high resolution CT scan of the chest. And those patients have higher mortality. Because many patients with COPD, they don't get CT scan of the chest. Okay? But if you're getting a CT scan of the chest, please get high-res CT scan. This has been noticed a lot these days, the coexisting emphysema with pulmonary fibrosis. Okay? Presence of pulmonary hypertension. Remember, these patients are old, they are smokers, 60% of them are smokers. They may have a coronary artery disease, or they may have sleep apnea and pulmonary hypertension. But presence of sleep apnea is a poor predictor of survival. Okay? Okay. Physiologic predictors. If reduced FVC, total incapacity, DLCO at the time of diagnosis, or if they drop these things, FVC DLCO over 6 to 12 months. Okay? Significantly reduced distance during 6-minute walk test. May not be true in your patients, because in geriatric population you can have sarcopenia or musculoskeletal abnormalities or frailty. So it may not be very relevant. 6-minute walk test was projected as the test in early 2000, but slowly we are learning about in geriatric population. It's not a great test in geriatric patients. Okay? Exertional hypoxia, that's an important thing we need to remember. Okay. What is the cause of death? Coronary artery disease, lung cancer. 60% of them are smokers. They are prone for lung cancer. The existing scar can also lead to lung cancer. Okay? Infection, PE, and acute exacerbation of idiopathic pulmonary fibrosis. What is acute exacerbation? So it's a worsening of dyspnea within few weeks, less than a month, and we shoot a film. They have diffuse opacities, they have hypoxia, you have ruled out CHF, you have ruled out pneumonia, you have ruled out PE, and sepsis. Okay? So we came out with the word acute exacerbation of IPF. This is the diagnosis of 21st century. We did not have that in last century. Okay? And rate of acute exacerbation ranges from 10 to 15%.
Is there an ICD-10 code for that now?
Yeah, they do. They do. Okay, and risk factors for acute exacerbation of IPF are unknown. So I told you, when you do the surgical lung biopsy of idiopathic pulmonary fibrosis, you find usual interstitial pneumonia, right? But if you biopsy acute exacerbation of idiopathic pulmonary fibrosis, you see the features of diffuse alveolar damage on the top of UIP features. This question came when I restudied for IM boards. So people who restudy for IM boards, please remember this question. They ask about acute exacerbation of IPF in internal medicine boards, and so histopathology was the question there. Diffuse alveolar damage on the background of UIP. Okay.
Is that A, B, C, or D?
Okay. But I hope I have convinced you about UIP and diffuse alveolar damage. Okay. If they survive one episode, they are prone to get the second episode of acute exacerbation of IPF. Okay. These are the slides I prepared specifically for this lecture. Remember, the IPF in elderly, they are signed off, it's like a terminal death, but here is the mortality, okay? Yes, the mortality is high, above 80, but it's not, it's about 8 years when you diagnose between 66 to 69. But this is based on ICD-9, okay? They specifically say this is ICD-9. And this is the paper, median survival and mortality risk factors for idiopathic pulmonary fibrosis in Medicare beneficiaries. 70 to 74, 6 years. 75 to 79, 4.5, then 2.5. So I think your approach will change as per the age here. And of course, women always live longer with this condition than men. Okay, and ethnic group, African Americans survival is slightly better, but it's not statistically significant. Okay. Any questions on the survival? This should change our viewpoint, because if you ask a lot of my fellows, they'll say survival is 3 to 5 years. But if you diagnose in this group, it's 8 years. Okay. So treatment, you should remember chronic progressive disorder. 3 years survival is 50%, but higher the age, higher the mortality. Lung transplant is the only therapy shown to prolong survival in advanced IPF. I have good news for you on lung transplant. I'm going to tell you that one. Okay. So what you do is you have to enroll them in pulmonary rehab. Okay. And we have to remember in geriatrics population about frailty, sarcopenia, and musculoskeletal abnormalities. Okay. I'm a big believer in oxygen supplementation, and you have to be very aggressive in oxygen supplementation. It's the cheapest and non-toxic treatment. Okay. please evaluate them at rest with spot check and also with a blood test. Then walk them in your clinic or in our lab, we do it free for you, okay? And then we also check them during sleep, okay? I usually do not give codeine to my patients at all. I send them to a GIM clinic. But this is the only group of patients I give codeine because these are older patients. They can break their ribs due to violent cough. It's a violent dry cough. Go ahead.
Pulmonary rehabilitation right here in the city, where is it available and how we can refer to that?
It's
Refer
available
our
even in
patients.
SLU, but you should not call it as pulmonary rehab. You should call it as physical education and endurance training. And you should always put a diagnosis of debility. If you say IPF, 516.3, that's the code. And then below that, I don't know the ICD name for the debility. You have to have the diagnosis of debility. Then you can send them for physical education and endurance training. Otherwise, Medicare will not pay. Okay.
So they can only have 6 weeks then, right? 4 to 6 weeks.
They can go up to 21 weeks.
Consistency of physical therapy?
Yeah.
Where is it performed at here? Like we're at on campus?
It's on the first floor.
In the hospital?
In the
So this is the
hospital.
physical therapy part?
Oh, okay.
Oh, okay.
Yeah.
Okay.
I have 2 medications and I want to learn something from you today. I'll tell you about these 2 medications, but then I want to ask you whether I should use it in a geriatric population because Dr. Morley presented in his grand rounds, anybody takes more than 5 medications, they have increased incidence of mortality and fall risk. So I would like to show every single side effect of these 2 medications and learn from you, okay? Okay. There are 2 trials. These medications were approved in 2014. One of them is nintedanib, okay? It works on a platelet-derived growth factor and fibroblast growth factor and vascular endothelial growth factor. And what this medication did, they did not improve the survival, okay? I'm going to tell you that. But they declined the reduction in the rate of decline in FVC at 1 year. And it also decreased the risk of acute exacerbation, okay? AE is acute exacerbation, okay? And the second medication, this medication has been around in Asia and Europe before it was approved in the US. Again, same story, it's an antifibrotic mechanism. It also decreases the rate of decline in FVC. All of us, up to the age 35, we drop our lung function, okay? My FEV1 will decrease by 35 cc's per year. If somebody smokes, FEV1 declines by 3 times. That's why smoking cessation helps in COPD, okay? So, whether you have ILD or no ILD, your lung function will drop. But with the ILD, with fibrosis, it will drop further. These 2 medications will bring it back to the normal level of drop. Okay, that's the main basis of the approval by FDA. Okay, so, and I'm going to show you more after this lung transplantation. I said I have good news for you. Okay, they have the lung transplantation criteria for ILD has been changed. Now it has been increased from 70 to 75 years. So I don't know your philosophy about transplanting patients who are in 70 to 75. You guys are okay with that?
That's on our life expectancy otherwise.
Yeah. If it's a single disease. Okay. So that has been changed. So that's the, according to the most recent thing, it was changed only last year. So the now age for transplantation is 75 years for interstitial lung disease. If they have evidence of radiological and histological evidence of UIP, either or. See here, you don't need both of them. This is what I do. I get a high-risk CT scan, I get a PFTs, I have a detailed history. The moment I diagnose UIP on high-risk CT scan, my dictation also goes to lung transplant center on the same day. I refer them on the same day. I may do oxygen, I may send them for pulmonary rehab, but I refer them on the same day. Because you attended Dr. Keller's lecture last grand rounds, you know, only 2 out of 10 cadavers have transplantable lungs. Waiting for lung transplant is much longer than for any other organ, okay? And do we have to do single lung or bilateral lung transplantation? Dr. Keller did show the trend is towards a bilateral lung transplantation, but I'm going to show the newest guidelines on this one, okay? So this is for the policymakers like Dr. Morley when he goes for Washington for a meeting. And so I told you this will cost you $2 billion, okay? So what they did was, this is ICD-9, it's not ICD-10 yet, okay? So they divided them in two groups. This is after enrolling in studies after diagnosis for first 1 year, and this is after 1 year, okay? So patients with IPF cost you more, and this is for patients. It could be outpatient hospital visit, skilled nurse facility, hospice, everything. So ILD will cost you more. They will cost more for the healthcare, okay? And this is the newest guidelines, 2015 guidelines, and this is the 2011 guidelines. If some people did anticoagulation, please don't do it. I request all of you, do not try any empirical steroids for these patients. You know this better than all other doctors. These patients have osteoporosis, sarcopenia, musculoskeletal abnormality. They die sooner with aggressive therapy. Okay, especially I have used this prednisone, azathioprine, and acetylcysteine, and they did a study and they showed more mortality due to this combo. But before that study was published, I have used this combo because that was recommended in consensus guidelines in the past. Do not use any of this ambrisentan, imitabinib, nothing. So I'm going to show you 3 more slides on these 2 medications to get your opinion. Nintedanib and pirfenidone is conditional recommendation for use, okay? And don't use sildenafil. Antacid therapy. You always know pulmonologists always treat gastroesophageal reflux disease in these patients with antacid, H2 blocker, or proton pump inhibitors. It's all based on retrospective data. There is no randomized data, but it's still conditional recommendation by the committee. N-acetyl monocysteine, do not use it, okay? There are some pulmonologists, and I get so mad when I see this group of patients. They treat pulmonary hypertension associated with IPF with the pulmonary hypertension specific medication with sildenafil, or this sildenafil for 1 year costs you about $10,000. Bosantan costs you about $4,000. And the other medications cost $100,000. What happens if you give vasodilators to already fibrosed lung? You make DQ mismatch worse, and they become more hypoxic, and they die sooner. Okay, so you should not use it. But if they have pulmonary hypertension due to heart failure, due to diastolic dysfunction, treat it. You know, you can still develop heart failure with the diastolic dysfunction. Nowadays, the word is heart failure with preserved ejection fraction. Okay, and that's way more common in this age group. Treat it. Lung transplantation, I told you. This is the brand new guidelines from this 2015. They did not touch this one. They still, you can go for single lung transplant or a bilateral lung transplant. Okay. Any questions on this new guidelines? To summarize these guidelines, if you have a patient with the IPF, you do the pulmonary rehab, you treat their cough, you treat their gastroesophageal reflux disease. 2 medication I talked to you about, nintedanib and pirfenidone, have conditional approval. Lung transplantation is the modality of choice. And a lot of other things, please don't do. Okay? And like the comorbid disorders and complications associated with IPF in elderly patients, you can divide them in intrapulmonary and extrapulmonary. If you treat these things, you can improve the quality of life. If you treat, angina, if you treat reflux, many of these patients can have sleep apnea. If you treat sleep apnea with CPAP, that quality of life will be better. Anxiety, depression, you're way better than me in this one. Deconditioning, you know how to treat it. Frailty, and this is the one you can put deconditioning also for a rehab. frailty and osteoporosis, I don't dare to speak to you guys about these three topics, you know way better than I do. Osteoporosis and diabetes mellitus, if you treat these, the quality of life does improve, okay? And heart failure, and this A stands for preserved ejection fraction. Remember, many times when we send the patients to cardiology, they treat only if there's a systolic dysfunction, but never treat the diastolic dysfunction. But treat diastolic dysfunction with appropriate medication, okay? Chronic cough, I told you about treating with codeine. This is the only group of patients I use codeine. Is codeine okay from your standpoint in this age? Okay.
Cough.
Okay.
If they're going to pass out from coughing,
Yeah.
it'd be better.
They can have cough syncope.
Constipated.
Yeah. Acute exacerbation, you have to treat with the broad spectrum antibiotics and ventilatory support. Pneumonia should be treated aggressively, okay? PE, if the patient has PE, of course they need antithrombotic medication. Pulmonary hypertension, treat if it is due to OSA or heart failure, not due to IPF. Please don't give them medication, okay? Of course, if they have COPD, concurrent COPD, you can use the appropriate bronchodilators. This article was meant for, this is the topic. This is published in Chest 2015. This says idiopathic pulmonary fibrosis in elderly, and they summarized in 3 slides here. I summarized in these slides. Promote and facilitate patient participate in decision making. Okay, supportive care. We talked about this. Avoid cytotoxic medication. We talked about it. Consider these 2 medications, and you have to encourage them to participate in clinical trials so that we learn from these patients. And lung transplant is up to 75 years. And I talked about all these things, but this slide summarizes everything, including only thing I did not talk about is insomnia here. And these are the slides for my own education from you, okay? Please tell me whether you will use these medications in this age group. If I have a patient, and I want to tell you, these 2 medications did not enroll patients above 80 years, okay? And they excluded patients above 80 years. And these are the side effects. Elevated liver enzymes, photosensitivity, GI disorders. Elevated liver enzymes, GI disorders, and embryo-fetal, that's not important. But with these adverse effects, if I have an 83-year-old with IPF, should I use it?
No, to improve symptoms.
And 83 was not included in the studies. And I have patients who are above 80 with these conditions. Or should I just say oxygen, pulmonary rehab?
Did they measure quality of life?
Well, it didn't improve symptoms.
It didn't.
It didn't improve
I didn't know,
symptoms.
okay. I saw the FEV one.
No.
Yeah.
Didn't
Subjective
improve
symptoms did not improve, so I would not.
Subjective symptoms did not improve.
No.
An improved 6-minute walk,
Yeah.
which is a subjective symptom in people who can't.
Pirfenidone did, not nintedanib.
Yeah, that's one of them. I mean, your data is just non-existent to treat anybody. I mean, you
Yeah.
can't approve drugs with the data that you just showed us. I mean, I know the FDA does it all the time, particularly if they're really expensive.
Yeah.
You know, it took them 20 years to approve metformin in this country
Yeah.
because it was a safe, good drug that was going to make people better. But things like this, they'll approve without any trouble. You don't have the data. They should have forced them to go back and get more. You need
The data's
mortality
about
data.
as good as Aricept.
Hmm?
The data's about as good as
Yeah,
Aricept.
another example of drugs you shouldn't approve. Okay.
Only the question is, how many of these toxicities, the way the oncologists grade
Yeah, well,
toxicities?
if we compare it to oncology, it's
But
not
what
good.
they said, I read it in detail because of this grand rounds. Most concern they have in elderly was this one.
Which is what?
Metabolized primarily in liver, and it will interact with multiple medications they will take.
Yeah, that's the problem. The tentative is about 5 of the enzymes.
Yeah.
So if you're on 3 or 4 other cardiac drugs. or
But does it really matter if your enzymes go up if you're going to die? in
No,
2
no,
to
what the
3
problem is
years?
it interacts and
Medication
raises
reactions.
the.
Medication.
Well, then you stop all the other medications.
But why would you
You're only allowed
pass
5, wait a
anybody who is
minute.
already experienced in polypharmacy anyway? Why would you give them?
I wouldn't I mean, you're looking at improving quality of life. If you really can improve 6-minute walk, that most probably is still the single best thing of whether or not you're improving quality of life. And the question is, does it improve it over what you get with appropriate pulmonary rehab? So you would first have to know what they did as a control. Did they do pulmonary rehab as a control, and was it appropriate?
No, I have the data at the end. As I said, I have a lot of extra supply for fellows here, and I kept the data at the end here. I'll show it in a little bit. See, these are the data. The annual rate of decline. If you compare nintedanib to placebo, it did decrease the rate of decline of FVC.
Does it improve mortality?
No. But what they said was, this is what they wrote in a paper. This should increase the survival, but the study did not show it.
No, it wasn't powered.
It was
Oh,
a
they were
powerful
followed
ad.
for 1 year.
Yeah.
So the real question is the 6-minute walk. I mean, forget everything else. If they
Go back
can,
one, go back one.
if they can improve
Yeah, that one. What's
the
the bottom?
The
What's the
thing
bottom
is,
one?
if they didn't have an
Go back
active
one.
control.
This
which would
one?
be
No, no,
pulmonary
next.
rehab, you
Yeah,
can't
next.
exclude
Next.
anything like
That one,
that.
that one, that one. What's the bottom graph on that? Because the curve's split there.
The top is placebo and the bottom is...
unreadable.
The dose, it's the dose thing.
Cumulative incidence
Okay.
of first reported acute
Exacerbation.
Okay.
So is there a difference there with the acute
Yeah,
exacerbation?
acute exacerbation was different.
More-
So it decreased acute exacerbation, improves 6-minute
So this is what I would like to tell. So if I have a patient who are above 80, and I think what Dr. Morley said here, so I would like to offer them and explain all the side effects. If you have these side effects, I'm going to stop this medication. Because there is nothing else we can offer. Because
So
if you're
first
80,
you check that they could actually understand you, because a lot of people over 80 are cognitively impaired. So you can tell them all of this and they'll say, "Doctor, what do you want me to do?" Or they'll say yes or no without thinking. I mean, that's a problem. It's very difficult to know what to do. But I really do think if you can improve 6 minutes walk by 50 meters, and I don't know if that's what they improved it by, but by the 50 meters, that's the difference between being able to get from your lounge to the kitchen, which is high quality life for an older person who's stuck at home. If you can do that, it's most probably worth it, even if it killed you earlier, because it's a better quality life. But you didn't show how much it improved.
but would you use that if they have only IPF? See, some of these patients above 80, they also have heart disease. They also have other diseases.
Were any of them allowed in the clinical trial?
No.
Was this clinical
Well,
trial
they-
limited to uniquely healthy people? who
Uniquely
only
healthy
had
people,
one disease?
they excluded above 80 people.
No, I mean, that's the problem. But if you took a set of people who were, say, 65 to 80 or 85, and you could show that you could improve the 6-minute walk distance by more than 50 meters,
Okay.
and that the comparator was an appropriate pulmonary rehab, which is very rarely done anywhere. I mean, that means protein, it means doing aggressive exercise, which I doubt whether we do either of those here on vitamin D. And if you're doing all of those three things, and basically you can improve above that, it's very hard to improve almost any of these debilitating diseases above doing appropriate rehab.
Sure. But they did not compare with the pulmonary rehab, no.
Well, then how could they? Okay, why am I asking? Then I can't tell you whether I use it or not, because it's actually a useless drug until proven otherwise.
It does sound like potentially it can help people stay out of the hospital if it was decreasing acute exacerbations,
That's, yeah.
which would have a lot of other consequences, like...
Yeah, so did they measure hospitalizations? They should have measured.
They did measure the first reportable acute exacerbation. They did that.
I agree, that's a good...
But above 80 was not in the study. That's my only...
But again, how much are you improving the acute exacerbation? Is it, 1 in 5% of people?
But Dr. Morley, if they have one acute exacerbation, that can potentially kill them.
Well, but you're looking at people who are going to die anyhow. I mean, you've got to understand it's quality of life.
Wait a minute, everybody's patients die.
Yeah, I know, but these are people who have a much shorter lifespan than you would expect.
Sure.
And they've already got lots of other things going on. The question is does a single exacerbation make a difference to how long the group as a whole survives? And we don't know that. If it doesn't, you're not necessarily improving. I mean, you're lacking the data. You keep on telling us.
No.
You're not telling us what to do, but I don't have enough data to be able
For
to tell.
people who had a previous acute exacerbation excluded from the trial.
Most probably.
Yeah, they were excluded.
Yeah.
And
So
did
It's
it,
a first exacerbation.
First exacerbation.
did it improve symptoms? Did they measure cough, dyspnea? Did they measure symptoms?
No, they did not measure those things, no.
Because that will help me decide if my palliative
Sure.
patients will benefit from one of these.
Sure. But above 80, I will not hesitate to use this because they were in the study. But above 80, I know we have to have a conversation with the patient and their families. And
Then you would
explain.
never use a statin either, because none of those drugs are
Yeah.
seen in elderly. I mean, most of our drug trials were not done on older people.
So to summarize,
I don't know.
so the hallmarks of ILD are progressive shortness, progressive symptoms like cough and dyspnea, PFT abnormality, mainly restrictive abnormality and DLCO, decrease in the diffusion capacity of carbon monoxide, and radiological abnormality. And take-home message is high-resolution CT scan is the modality of choice for diagnosis. And if you have a radiologist who can diagnose confidently and pulmonologist agrees with that, do not subject this patient for biopsies, okay? And there are promising drugs. I'm not saying they are the drugs. They are promising drugs, pirfenidone and nintedanib. Maybe when they have expand the scope of studies, maybe I'll come back and present you more.
So a pulmonary transplant to the 75-year-old, so you can do it now. How much does that extend life? And do we know?
It has actually increased up to 5 to 7 years.
So and they would live at 75, 5 years anyhow.
No, 5, at 75, I showed you the data here. 3.
It's 2.5.
About 3 years.
Yeah.
Yeah, okay, but so you've got to take the comorbidity of a transplant. How long are they going to spend?
But the quality that they live with
It's much better.
Is much better.
much better.
Okay.
You know, you'll be off oxygen.
I'm not disagreeing. I like the idea, but it's, you know, I'd like to see the data in 74, 75-year-olds as opposed to looking at 60-year-olds and saying that.
Yeah, there are centers who claim double lung is better than a single lung transplant, but the evidence-based guidelines do not say that yet.
Yeah, thank you, Bobby. Great talk. The question on steroids, first, thanks for whoever said don't use them, sticking with that. But what about acute exacerbation?
Okay, there are two things about steroids. I would like to make clarify. In idiopathic pulmonary fibrosis, when you diagnose confidently, do not use steroids. Acute exacerbation of the IPF, you have to use the steroids because you have acute interstitial pneumonia at that time. Okay, but if you have non-specific interstitial pneumonitis, organizing pneumonia with cryptogenic organizing pneumonia, you have to use steroids. Okay, it's only in the UIP, idiopathic UIP, that's IPF, you do not use the steroids. Acute exacerbation of IPF, you do. Non-specific interstitial pneumonitis, you do. Cryptogenic organizing pneumonia, you do.
And one more time, cryptogenic versus UIP, what's the best way to differentiate those two?
Cryptogenic organizing pneumonia is acute.
Consolidation.
It's a consolidation. It's peripheral consolidation. You know, UIP is more of the picture is heterogeneous,
Yeah.
subpleural, honeycombing, and all those things. You can remember cryptogenic like it mimics bacterial pneumonia.
And why treating diabetes does that improve their outcome?
They didn't say that our outcome is just improves the quality of life. That just didn't comment that. You know, I don't know whether they
So
did not.
most of the data for diabetes, rightfully or wrongfully, has moved to somebody like this to a hemoglobin A1C of about 8 to 8.5, which is not treating diabetes. I mean, you know, so the question really is this going to help? And I think there are things that it may, but is there something specific, Or is this just because pulmonologists haven't caught up with the new recommendations
No,
for treating diabetes?
I think the latter is more.
Okay.
And I have a slide which I will leave it for everybody, comparing the different ILD with the steroid treatment to answer your question. But I have all the ILDs listed here. And so this is the thing it says here. How do you treat each patient with steroids?
And you're telling me that I can get 21 weeks of debility and physical therapy for people with debility as a diagnosis?
You have to put debility as a
I can't get it any other way.
But you need to write specifically for physical education and endurance training. Please do not write pulmonary rehab.
Okay. And did you know that, Joe, that you can get 21 weeks?
Yeah.
Did not know that.
Yeah.
It's very important, I mean, because that's all my patients now have to have that diagnosis and fundamentally forget the pulmonary hypertension.
Do you use any kind of performance scale to determine who you would do a match open lung biopsy on if you're not certain by the CT scan?
So if you have a patient who has ground glass opacity, then you'll have to go for VATS. If you have no honeycomb vein, the upper lobe predominant disease, then you may have to go for a VATS. If anything that is not classical, then you may have to go for a VATS, lung biopsy.
But who would you say is too frail to undergo a VATS?
I think frailty should be defined by you, and that's the main thing. And if you say, there are criteria for diagnosing frailty now, and then we will not do it. And there is no point in doing VATS if the lung function is already less than 30%. What are you going to prove? Nothing. The patients will die after the surgery. They will come to ICU, and they will die in the ICU. So you should do it when a moderate decrease in the lung function, not with people with a severe restrictive ventricular limitation.
Maybe don't you have a plane to catch?
No, sir. But that's
You got time.
Thank you very much, Ron.
Thanks a lot. That's really good.
I have read the slides.
Now I'm afraid we're going to chest X-ray.
Yes. My wife is making it.
But I'll see.
No, I can't.
Myself and take everything.
That's based on your meeting tomorrow?
He gets in trouble for all these horrible things.
I can't look at you.
Don't talk to me, don't speak to me.
Oh, the last thing. We want to